Good afternoon and welcome to today's NAJA Roundtable, Health Equity, Aging, and Healthcare Disparities in Indigenous Communities. This webinar is part of a covering health equity series hosted by the Native American Journalists Association and a Healthcare Reporting 101 series hosted by the Association of Healthcare Journalists. This series examines the unique challenges confronting journalists who cover healthcare and health equity in Indigenous communities. Today's roundtable is intended to help journalists explore the challenges facing Indigenous elders as they seek to age with dignity. Panelists will discuss policies and social determinants of health that impact this and discuss how journalists can report on these issues while avoiding tropes and stereotypes in the spirit of the NAJA bingo card. This webinar is being recorded and the recorded video will be available on the NAJA website and YouTube channel. This roundtable series will not be possible without the generous support of NAJA and AHCJ sponsor, the Commonwealth Fund, as well as NAJA sponsors, Craig Newmark Philanthropies, Democracy Fund, Ford Foundation, Gannett Foundation, Google News Initiative, Knight Foundation, Oklahoma Media Center, Tegna Foundation, the Society of Professional Journalists Foundation, and Walton Family Foundation. Our panel moderator is Catherine Reed, AHCJ's Interim Executive Director and the Executive Director of Education and Content. Catherine may take questions from the audience as time allows. Please use the Q&A option at the bottom of your Zoom window to submit a question. Catherine, take it away.
Thank you so much, and good afternoon or good morning, depending upon where you are. Thank you for being here. The Association of Healthcare Journalists is based in the School of Journalism at the University of Missouri in Columbia. I would like to just take a minute to acknowledge that Indigenous people are here in our community now. They were here in the past. We at AHCJ wish to acknowledge and celebrate their past and continued contributions and ensure their history and voices are uplifted. We hope this webinar contributes to that effort. AHCJ was created 24 years ago to support and improve healthcare reporting, and we now have more than 1,400 members. Part of the way we support healthcare journalists is through our core topic leaders who specialize in particular subjects and produce content on those subjects for our members on our blog. Liz Seegert, one of our panelists today, is one of those core topic leaders, and she specializes in the topic of aging. Liz is a freelance journalist based in New York. Our other panelist is Travis Snell of the Cherokee Nation, former Cherokee Phoenix assistant editor, and he will help lead the discussion. Liz, do you want to get us started?
Sure. Thank you, Catherine, and good morning, good afternoon, everybody. Let me just pull up my presentation and we can get going. So as Catherine mentioned, I'm a freelance health reporter and I cover aging. I've been covering healthcare for a long time. And if you haven't yet written about aging, you probably will, because really aging is the story of not only the decade, but probably the 21st century. And that's because the graying of America is really inescapable. Older adults are projected to outnumber kids for the first time in US history by 2030. Those 65 and older will make up 21% of the population by then, up from 15% today. And by 2060, they'll be pushing close to 100 million 65 and older adults. The 85 and older population will nearly triple to 19 million. But let's talk a minute about how we actually define old. First, I'd like you to disabuse yourself of the idea that everyone over age 65, which is how most data is presented, is alike. Gerontologists, those who study aging, and geriatricians, those who consult on, treat, and care for frail and disabled older adults, divide old age into 3 stages. There's the young old, the middle old, and the old old. The differences here are in both physical function and cognitive decline. By the time you get into the 85 plus range, frailty and cognitive decline make living independently often next to impossible. although you always hear stories about those outliers. So when reporting on the aging population, try to present information which reflects the functional status and care needs of the average senior, rather than those who either are financially secure, active agers, or those who are pictured as decrepit and incompetent. And along with these general trends for America's elders, the American Indian and Alaskan Native older population is also growing. If you can see the chart, it will be, this population will top almost 650,000 by 2060. And despite increasing longevity, the AIAN population has a lower life expectancy, lower quality of life, and disproportionately are affected by many more chronic conditions than other racial and ethnic groups. So for example, while the US life expectancy is about 77 years, the AIAN life expectancy is 71.8 years, and that's the lowest compared with other races and ethnicities. American Indian and Alaskan Native individuals also have higher death rates for most of the top leading causes of deaths among most age groups compared with whites, Blacks, and Hispanics. So why is that? There are many factors that affect lifespan. Multiple comorbidities like heart disease and diabetes, obesity, food deserts and food insecurity, tobacco and alcohol use, physical activity level, housing, crime, importantly, access to preventive care. And surprisingly, and this actually surprised me when I was doing the research, genetics only plays a small role in longevity, less than 7%, according to the most recent studies. The 5 leading causes of death among AIAN males are all preventable or at least treatable chronic conditions: heart disease, cancer, chronic lower respiratory diseases, diabetes, and stroke. Among AIAN females, the first 3 are also the same, but if you notice, stroke and diabetes have flip-flopped. So women tend to have more issues with stroke than they do diabetes. And among the risk factors, especially for heart disease, obesity, because at least 1 in every 3 AIN adults are obese. And 2 of 3 don't do any physical activity, not even once a month. AIN people over 50 are 30% more likely than other groups to have high blood pressure and 20% more likely to smoke. And that's the highest prevalence among all groups. But I do want to bust one myth, which is about alcohol consumption. It's comparable or even lower than among the same non-AIAN groups, particularly among whites. However, this population also has a tougher time accessing care, including preventive care. There's a lower prevalence of having a personal doctor or healthcare provider, 63.1% compared to whites who have almost 73%. And older AIAN adults are more likely to have difficulty accessing healthcare compared to their peers in the non-AIAN population. Part of the reason is they don't trust the government health system. There's lack of accurate information, particularly on things like Alzheimer's disease. Transportation and long distances can be a problem. Many are underinsured. A majority of AIAN population 65 and older have Medicare, but many who qualify for Medicaid don't sign up. There's a lot of discrimination and lack of culturally appropriate care, whether that's healthcare providers not speaking a native language or being aware of cultural traditions, or just not treating people in a culturally sensitive manner. And then when it comes to caregiving, proximity to family is often difficult, particularly if you live on tribal land or in rural parts of the country. Apparently, at least half of AIAN population 50 and older live in non-rural areas, but still have difficulty accessing culturally relevant services and supports. And that was another statistic that kind of surprised me. So there's definitely a need for that out there. Now, there's many issues that affect older people of all ages and backgrounds. The lack of family care workers, both caregivers from family and direct care workers. There's a lack of housing options. Nursing homes, assisted living, and senior communities are nice, but they're very costly at times if you don't have the right kind of insurance, and they're often even not available. Your housing could be unsafe. There could be clutter. The stairs pose a fall risk. The house could be in disrepair and not be safe to live in. There are waiting lists for home and community services, transportation issues, elder fraud and abuse, lack of easily accessible age-friendly programs and services, and plain old ageism, where old is bad and young is good. But there are also some aging issues that disproportionately affect AIA and elders. Falls, for example. While 1 in every 4 elders of all backgrounds, 65 and older, fall every year, which can lead to injuries like hip fractures and head trauma, AIAN elders report the greatest percentage of falls at 34.2%. And a 2012 survey by the New Mexico Behavioral Risk Factor Surveillance System found that 1 in 3 American Indian elders age 45 and older in New Mexico fell at least one time in the past 12 months. And 45% of those were injured. And these injuries, whether it's a hip fracture or a head injury, can also increase the risk of early death. Why are there so many falls? Diabetes is a big culprit. Diabetic neuropathy leads to loss of feeling in the lower extremities. Diabetes increases the odds of osteoporosis. So your risk of fractures from a fall go up. And American Indian Alaska Natives also have higher rates of other chronic illnesses, which increase risk of dying if you do fall. Another issue that disproportionately affects AIA and elders is heart disease. In 2018, AIA and elders were 50% more likely to be diagnosed with heart disease than their white counterparts, twice as likely to be current cigarette smokers, and 10% more likely to have high blood pressure compared to non-Hispanic whites. So you can see the ratio here that the data says skews 50% higher. Cancer is another problem in this population. Native populations in the United States have unique cancer patterns due to their history and culture, where they live, how they get health care, and institutionalized racism. For instance, rates of getting lung, colorectal, liver, stomach, kidney, and other cancers are much higher compared with non-Hispanic whites in the US. And while the CDC routinely tries to link cancer data registry and death certificate data with the Indian Health Service to identify Native people correctly, this information is frequently misreported as being members of other racial groups. So the rate may actually be higher. And what this chart is showing you is where the rates are. Light blue is the American Indian Alaska Native population, and the purple is the non-Hispanic white population. So we've got Alaska here where you can see the rates of cancer, the Northern Plains and the Southern Plains where the rates are also extremely high. Another problem, and I don't have a slide for this, but another problem is that by 2060, the number of AIANs 65 and older living with dementia is projected to grow over 5 times. And while longer lives provide additional time for older generations to share knowledge and traditions, older age also brings an increased risk for Alzheimer's and other dementias. So this is pretty depressing information, but there are some solutions. For example, long-term services and support. Most people want to continue to age in their community, and many don't know that Medicare does not pay for long-term care unless it requires skilled nursing. So for example, if you had a hospital discharge and needed a nurse to come to the house occasionally. So Even then, it only pays for 120 days at a time. Medicaid is what pays for most services like nursing homes or special home-based programs that allow elders to live comfortably at home. And when I talk about home and community-based programs, I've listed a few here, and I will post in the chat a list of additional resources on these. These are home and community-based services enable elders to remain in their homes for as long as possible. That may include nutrition assistance, congregate or home delivered meals, in-home services like personal care, chores, or home maintenance, transportation for basic medical needs, physical therapy, dialysis, and case management. The ones I've listed here are extremely popular, extremely proven, and shown to net result in better health outcomes. PACE is the program of all-inclusive care for the elderly, which is a Medicare and Medicaid program that helps people meet their needs in the community instead of going to a nursing home or other care facility. Team of healthcare professionals works with individuals and their families to ensure they get coordinated necessary care to improve and maintain health. Capable, which was developed by the Johns Hopkins School of Nursing, team of nurse and occupational therapist and a handy worker to modify the home of an older adult, and emphasizes the strengths that older adults themselves can rely on to set goals and improve safety and independence. Money Follows the Person is a federally funded Medicaid program that supports states in their efforts to transition Medicaid beneficiaries from living in institutional settings like nursing homes to living in the community. And when I say community in this case, it can mean they return to the home they were living in, they can live with a family member or a friend, or even in a small group home, as long as there's no more than 4 unrelated individuals in the residence. There's also the Native American Family Caregiver Support Program for those people caring for their older relatives, people with Alzheimer's, or grandparents raising grandchildren. This program provides education, assistance, case management, emotional support and resources, training, respite care, and some supplemental services like assisted technology. Then there's the Well Balanced program, which is the Wise Elders Living Longer. That's a group program specifically designed for Native American elders. It uses exercise, information, and social interaction to help elders remain active and independent in their own homes as long as possible. Importantly, it includes fall prevention, chronic disease management, socialization, strategies for independent living. And then there's a Healthy Brain Initiative Roadmap for Indian Country, which is a guide for AIAN leaders to learn about dementia and start discussions throughout their communities. The guide suggests 8 strategies that embrace community strengths, and it can be tailored to the unique priorities of each community. There are also some local programs, which Travis will touch on. So now that I've made your brain explode with all this data, how do we report on it all? I said earlier that aging and all its related issues is still the biggest health story of the coming decades, and I strongly believe that. The longevity revolution created a wealth of cross-cutting issues, challenges, topics, and trends that all journalists need to cover. And some of these, where they intersect, are easy, like Alzheimer's impact on long-term care, or family finances, or the effect of new drugs on chronic conditions. Others, including some of these issues, take a little more digging. For example, the increase in complex care management being done at home, or the roles that subspecialists like therapists and disease management educators play in the role of chronic conditions, or the need for additional social service help in housing, transportation, and how that affects chronic care. And of course, the need for culturally appropriate care that honors and respects traditions. And there are more story ideas we can discuss during the Q&A. But let me leave you with this advice. Don't lump all older people into one big group. Understand different stages of aging, the ups and downsides, and that most people are not on the extreme ends. Most older people are happy, relatively healthy, and cognitively intact. So please don't feed the myth. So that's it for now. My contact information is up there, and I will turn it over to Catherine.
Thank you, Liz. I appreciate that so much. I love the idea, and it can't be emphasized enough that, this is not one big group that you can characterize with generalizations. Good stuff. All right, Travis, are you ready to join us?
Yes.
Okay, can you turn your camera on? There you go.
There we go.
Hey. All right, Travis, walk us through some sort of a local perspective now.
Well, some of this stuff isn't really local, but it may. I think we'll get some good information out of it anyways. There is some local stuff at the end, but here we go. Let's see. I remember how to do this correctly. All right, are you able to see my screen?
Nope, not at the moment.
All right. How about now?
There you go. Now we got
All
you.
Okay. As Liz said, by 2030, the population of elder natives is estimated to increase to around 443,000 and to more than 648,000 by 2060, according to the National Indian Council on Aging. With this expected rise in native elders, I think it's imperative that healthcare for them improves, but they have long faced healthcare challenges in the U.S. and continue to face them. Some of the historic disparities obviously has been the big one, failure of U.S. trust responsibility. According to NICOA, treaties between American Indian and Alaska Native communities and the federal government state that all federally recognized tribes have a right to healthcare services. The Indian Health Service was created to meet this commitment. According to IHS, citizens of 574 federally recognized AIAN tribes and their descendants are eligible for its services. Is tasked with providing a comprehensive health service delivery system for approximately 2.6 million of the nation's estimated 5.2 million American Indian Alaska Natives. According to the National Congress of American Indians, IHS appropriations have never been adequate to meet basic patient needs, and healthcare is delivered in mostly third world conditions. The IHS faces significant funding disparities, notably in per capita spending between it and other federal healthcare programs. The Government Accountability Office finds that in 2017, IHS per capita spending was $4,078, as compared with $8,109 for Medicaid, $10,692 for the Veterans Health Administration, $13,185 for Medicare, and $8,600 for federal prisoners. New healthcare insurance opportunities and expanded Medicaid in some states may expand healthcare resources available to American Indian and Alaska Natives. However, these are no substitute to the fulfillment of the federal trust responsibility, as the budget gap remains, the NCAI states. According to the fiscal year 2023 federal budget request, President Joe Biden requested $9.1 billion for IHS, up from $6.2 billion in fiscal year 2021, but that's still $40.7 billion less than the tribal budget formulation work group requested. Also, according to NICOA, there have been at least 296 tribes receive federal Older Act or OAA Title VI funds. NICOA recommends the federal government increase funds for caregiver programs, increase funding for Title VI, move Title V set aside funds to Title VI, implement and establish a White House Conference on Indian Aging, and elevate the director of the Office of American Indians, Alaska Natives, and Native Hawaiians programs to assist Secretary of American Indian and Alaska Native elders. NICOA states that increased funding should ensure that tribes receiving Title VI funds maintain funding levels that will ensure services are delivered and at 1.5 times the inflation rate as costs are higher on tribal lands. And for more than 40 years, tribal elders and officials have recommended the implementation and establishment of a White House Conference on Indian Aging. The meeting would recognize the federal trust responsibility and be equal to a national consultation between Native elders and the U.S. government. The elevation of the Director of the Office for American Indians, Alaska Natives, and Native Hawaiians programs to Assistant Secretary of American Indian and Alaska Native Elders is another recommendation submitted during the past 40 years to no avail. The elevation of this office to Assistant Secretary with jurisdictional authority is a recognition of the importance of the unique government-to-government relationship between Native tribes and the U.S. Another point is access. According to NACOA, although there are 574 federally recognized tribes, there are more groups seeking federal recognition. Therefore, some AIANs are not eligible for IHS services. To further compound challenges, IHS services are primarily focused in rural areas, in spite of the fact that 78% of them now live in cities and urban areas. According to the Centers for Disease Control, with IHS, access to healthcare services is not only available at federal hospitals, is only available at federal hospitals and clinics operated or funded by IHS, and might not ensure that AIANs have ready access to health interventions or coverage to see non-IHS providers. Thus, although respondents reported having healthcare coverage, many might not be able to access care beyond IHS facilities. According to an American Bar Association report, a common challenge in many rural communities is the shortage of medical personnel, a problem that is even more severe in tribal communities, especially those in remote reservation locations. The CDC also states that prevalence of having a personal doctor or healthcare provider was lower among American Indian and Alaska Natives than among whites and others. Historically, IHS facilities are located in geographically isolated areas on reservations. As the AIAN population has become younger and more racially diverse, larger numbers of them are residing in cities, limiting continuing care through IHS and possibly the ability of AIANs to obtain and retain a personal doctor or healthcare provider. Studies have highlighted additional barriers preventing AIANs from accessing providers, including long wait times, travel times to an IHS facility, lack or limited access to transportation, culturally and linguistically appropriate providers, a full range of services, preventive care, screening, and early treatment for health conditions. Factors such as having a regular source of care, language and communication barriers, lack of diversity in the healthcare workforce, high rates of poverty, lack of health insurance, discrimination against AIANs, and large distances from healthcare services have all added to the disparities that affect AIAN communities. And about a quarter of them have reported experiencing discrimination when going to a doctor or health clinic. According to findings of a 2017 poll by NPR, the Robert Wood Johnson Foundation, and Harvard T.H. Chan School of Public Health, AIANs who live in areas where they are in the majority reported experiencing prejudice at rates far higher than in areas where they constituted a minority. In places where there are fewer AIANs, they are misidentified, which is yet another form of discrimination. According to at least 2 studies in recent years, AIANs in the American Southwest were routinely viewed as non-compliant by medical providers. In the studies, medical providers completed a questionnaire assessing their awareness of stereotypes that healthcare professionals associate with AIAN patients, then completed measures of their motivation to treat them in an unbiased manner. Despite being highly motivated to treat individuals fairly, the majority of participants reported awareness of stereotypes associating these patient groups with non-compliance, risky health behavior, and difficulty understanding and or communicating health-related information. The research provided direct evidence for negative health-related stereotypes associated with AI/ANs among nursing and medical personnel. As for affordability, research from the University of North Carolina, Gillings School of Global Public Health shows insurance coverage among American Indians and Alaska Natives in the Midwestern region is still lacking, despite Affordable Care Act provisions for these underserved populations. There are many barriers to health insurance coverage for American Indians and Alaska Natives, including low employment rates and a distrust of healthcare institutions. While a common misunderstanding persists that the IHS meets the healthcare needs of these populations, many individuals are not in areas covered by the IHS and experience significant gaps in insurance coverage. According to the IHS, the Affordable Care Act was created to expand access to coverage, control healthcare costs, and improve healthcare quality and coordination. The ACA also includes permanent reauthorization of the Indian Healthcare Improvement Act, which extends current law and authorizes new programs and services within the IHS. For American Indian and Alaska Natives, the ACA can help address health disparities by investing in prevention and wellness and increasing access to affordable health coverage. The ACA provides AI/ANs with more choices depending on eligibility and the coverage available in their respective states. They can continue to use IHS, tribal, and or urban Indian health programs. They can enroll in a qualified health plan or QHP through the federal marketplace and access coverage through Medicare, Medicaid, and the Children's Health Insurance Program. If a Native chooses to enroll in a QHP through the marketplace, he or she may simply qualify, or he or she may qualify for special benefits and protections offered to AI/ANs. Lack of culturally appropriate information. During their lifetimes, American Indian, Alaska Native elders have likely experienced poor services, barriers to access, and outright discrimination when trying to access healthcare. However, the new millennium has brought a push to improve healthcare systems, and recent legislation has reshaped the way healthcare is delivered to all people in the U.S. Culturally competent healthcare. While quality healthcare sounds simple, there are 6 aspects to healthcare delivery that determine the quality of care itself and the value to patients in the end. The Institute of Medicine developed 6 aims for improvement to healthcare in 2001, and they have influenced the direction of healthcare improvement in the U.S. These aims are safety, effectiveness, efficiency, equitability, timeless, and patient-centered focus. A patient-centered focus ensures that the patient is treated with care and consideration for cultural differences and their own unique healthcare needs. It ensures that medical professionals help patients understand their condition, the available care options, and respect the patient's healthcare choices. Creating a welcoming facility. Service providers face various challenges in meeting the needs of the aging population. One of these challenges is creating service delivery systems which consider the needs of a diverse population. Currently, American Indian, Alaska Native elders are often overlooked and underserved. This is partially due to the lack of understanding of where they access services, and because many services available to AI/ANs have not been culturally competent in their delivery of care. Additionally, many urban programs fail to meet the unique cultural needs of Native elder populations. An understanding of their belief systems can enable healthcare providers to more effectively and respectfully interact with Native elders. Recognition. With some 78% of American Indian, Alaska Natives living outside of Indian lands, the need to recognize Native people in facilities both on and outside of tribal areas is increasingly important. This can be a challenge because it is not always obvious or readily apparent that a person identifies as Native. Without recognizing an elder as AI/AN, it is not possible to understand the differing worldviews they might have or the adversities they face throughout history, such as racism and the many destructive U.S. Indian policies. It is important to note that beliefs are not homogeneous among Native elders. as some may have traditional views and others may not. Language, beliefs, and practices vary widely among these groups. Involvement. The Health Resources and Services Administration advised that the delivery of culturally competent care requires understanding of the patient's healthcare literacy. This is influenced by such factors as education and income, but for Native elders, it may more seriously be impacted by historical inequities in access to healthcare services and disparities in treatment. The HRSA also recommends the assessment of relevant cultural factors that might impact the patient's health. For Native elders, language and traditional practices are important cultural factors to consider alongside the many other aspects of diversity. Care that is culturally competent requires the inclusion and participation of the care recipient. It is not always possible to truly provide quality care to an elder without understanding who they are and where they come from. To ensure willing participation from an elder, their family, and their community in delivering any type of service, whether institutional or home and community-based, the involvement of the entire community in the development and delivery of care is critical. Involvement on a community level can help to identify the needs specific to the Native population served by their facility. While the specific beliefs of each Native nation vary and may be specific to that nation alone, there are some broader shared beliefs that apply to many. With regard to healthcare, the medicine wheel or sacred hoop is used by many for health and healing purposes. The medicine wheel contains 4 directions: north, east, south, and west. For tribes, the directions have different meanings. It may represent the seasons of the year, the stages of life, or aspects of life, but is always used to reflect a more holistic view towards life. Many American Indian and Alaska Natives understand that people are interconnected to their communities, to nature, and to the spirit world. With confronting an ailment, it may be viewed as a lack of harmony between the physical body and the mind, spirit, and emotions of a person. Accordingly, many Native people may choose to look towards Western medicine to address the symptoms of an ailment, while also pursuing spiritual guidance from traditional healers in their communities to recover from an imbalance between the mind, soul, and body. Traditional healers use medicinal plants and herbs, as well as sacred ceremonial practices, such as sand painting or sweat lodges, to help correct such imbalances in the patient seeking treatment. Since the introduction of Western medicine to Native communities, traditional practices have often been viewed as at odds with Western medical practices. Historical oppression and motives to force the assimilation of American Indian Alaska Natives have resulted in little consideration for such traditions. Taking action. Listening to the community and the specific individuals in the service delivery system is as important as developing programs specific to AI/AN needs. The historical neglect of the unique needs of Native people in the broader healthcare system has meant that many elders have experienced poor quality healthcare and may not be willing to trust a care provider that promises to hear their concerns but fails to act. Taking inclusive action means including AI/ANs in the delivery of care. Members of a Native elders community may be able to assist with unique needs in a culturally sensitive way that would otherwise not be possible for non-Natives. Hiring qualified AI/ANs as staff and into administrative positions can lend a shared perspective between those designing, giving, and receiving care, as well as create trust on an individual and community level. Inclusivity can be demonstrated in various ways. One is by featuring Native people in promotional marketing materials. Recognizing traditional holidays and feast days and participating in Native community events can help create understanding, as well as learning the appropriate ways to show respect towards elders. Repeated efforts to reach out will help create a relationship of trust over time. Better healthcare outcomes for Native elders depends upon more than just providing the best medicine. With a better understanding of and respect for the whole individual, including their American Indian and Alaska Native culture, beliefs, and practices, better healthcare outcomes can be achieved. Disparities related to diet. Healthy eating in the modern world is not always easy. Fast food and prepackaged foods offer inexpensive and easy alternatives to healthier foods or cooking from scratch. Even in remote locations, you can find snacks like burgers, chips, candies, and sodas. However, these kinds of food can be harmful to our health in the long run. Diet and nutrition play crucial roles in overall health. A poor diet can have an especially dramatic impact on the lives of elders. American Indian, Alaska Natives in particular face a predisposition to obesity and diabetes. Historically, however, they did not face these health disparities. Research suggests that modern Western diet is detrimental to the health of all consumers, and especially elders. AIAN elders face disparate rates of obesity. Nearly 40% of men and more than 40% of women are obese. These rates are highest among elders ages 55 to 64 and are lower among older elders. The rates of diabetes among AIANs are more striking. More than 16% have diabetes, a rate more than twice as high as that of the general population in the US as a whole. Among AIAN elders, 30%, nearly 1 in 3, have diabetes. Some AIAN communities suffer even higher rates of diabetes. The Pima of Arizona have seen rates of diabetes as high as 60% in their community. It is important to note that while AIANs are predisposed to these conditions, they were very rare just 100 years ago. Traditional versus contemporary diets and practices. Diets have changed dramatically since the introduction of European foods into the diet of American Indian and Alaska Natives. The diets of AIAN ancestors contain more complex carbohydrates, such as whole grains, peas, beans, potatoes, and fewer fats, such as meats, dairy products, and oils. While diets vary from nation to nation, traditional foods consisted of those that could be gathered and hunted in the local area, and sometimes included agricultural products such as corn, squash, and beans, which were introduced before European influence on diets. The shift in the way AIANs eat come as a result of being removed from their homelands and relocated to reservations. The federal government discouraged them from continuing their traditional hunting and gathering traditions and provided commodity foods such as white flour from wheat and lard to their communities. Such food products are completely foreign to their traditional diets. Combined with the destruction of traditional practices, the diet of the present day has contributed to the disparities in health faced by American Indian, Alaska Natives. Those eating a contemporary Western diet now experience processed foods high in simple carbohydrates, salts, and fats. One example of such a food that is commonly found in Indian country is fry bread. Fry bread found today is a product of the shift from traditional foods to government-issued commodities, which have little nutritional value and can negatively impact health. Access to food. Elders living on a reservation or in a rural area may have very limited options about where to purchase food, as well as difficulty accessing these places at all. Many live, whether in rural areas or large cities, in what is known as a food desert. For elders who no longer drive or those without access to a car or transportation, healthy food choices can be even harder to access. Low access to healthy food options combined with poverty and other factors mean that many American Indian and Alaska Natives face what is known as food insecurity, or lack of access to enough food to stay healthy due to a lack of money or resources. Almost 1 of every 4 AIAN households face food insecurity. There is also evidence to show that even those who have access to healthy choices often find them to be unaffordable. Eating indigenously. Recently, some activists in partnership with tribal nations and universities have begun to push for a return to traditional diets. One such movement is the Decolonizing Diet Project, started by Professor Marty Reinhardt of Northern Michigan University. It takes the perspective that the change in dietary practices that resulted from the colonization of North America is a form of oppression. This project and others like it in AIAN communities are researching what foods existed in traditional diet prior to colonization. By engaging elders the knowledge of generations is built and shared among the community in support of the local food system. Such programs also educate communities about traditional diets and the importance of embracing and reviving traditional practices. These programs also help increase physical activity among AIANs by encouraging hunting, gathering, gardening, and traditional preparation of food. They also promote the preservation of culture as well as access to healthy traditional foods within their communities.
Travis, I hate to interrupt, but it is 12:45 and I was wondering if you might be nearing the end of your slide.
Yes, I'm almost done.
Okay, because I want people to have an opportunity to put those questions in the Q&A.
Okay, let me see where we're at. Let's see.
Of course, we can share these slides with NAJA members too, and kind of go to the conversation. If
Yeah, I just got one more thing here. The changing diet, making one change at a time for a healthier diet. Instead of doing more than one thing, just make one change at a time. It'd be easy to reduce dependent on Western diets, and then reduce simple carbohydrates, snacks like soda and candy, et cetera, et cetera. And then I have the list of helpful programs and resources, and I'm done. So.
sorry about that, Travis. I just
That's
want to
okay.
make sure we have time to get to a few of the questions. Thank you so much. Let me stop your sharing.
Okay.
I don't think I have that ability anymore. If you want to stop your sharing, we can get us all up here again. So I want to go back to something you were talking about that I think is really important, and that is to cultural competence in care, or actually a lack of culturally competent care. And I was wondering if you would maybe share an anecdote or a personal experience about, what does that look like? I think that's an important subject for us to report on, and it's a cross-cutting health equity.
I've actually got two that I could share. One was with my grandfather. He died at the age of 72. He was a full-blood Cherokee. He died at the age of 72 in 1972, and he died on his front porch from a heart attack. And he refused to go to the doctors before several years as his health declined. He refused to go to the doctors because he didn't trust white doctors. They didn't speak Cherokee, even though he spoke English. He was sent to Chilocco boarding school back in 19-teens, and he learned English there, but he just didn't trust white doctors at the time. He had heard horror stories from his friends, and so he didn't have the medical care that he needed, and he died at age 72 from a heart attack. A better example is I have a friend who is a nurse, and she worked at W.W. Hastings Hospital in Tahlequah, Oklahoma, which is the capital of the Cherokee Nation and the United Band of Cherokee Indians. Both tribes are located in Tahlequah. She spoke Cherokee to her patients, her elder patients. She actually went out and learned how to speak phrases and body parts and stuff like that to learn not only the language, but also some of the culture about, because some things that, doctors want to do, some patients wouldn't allow it to happen because of a cultural difference. So.
Right. That's so interesting. So she actually went out and did the work. In a way, it really parallels what we learn as reporters about good reporting, which is that you have to go out and do the work to earn the trust. So this last piece of your presentation related to food and diet, I thought was really important for people to have on their radar as journalists. And I want to bring Liz in here and talk about just overall, like, what are some great story ideas related to diet and the aging population, Liz?
Well, I think Travis really hit on the idea of food insecurity. It's not
Right.
necessarily that you don't have food in the refrigerator, but that you're often forced to make choices. That if you're living on Social Security, you're living off of a pension, you have a fixed income, and you often have to decide between buying food or paying for your medication. And this is an issue that, crosses cultures and geographies. So you may have to forego a meal, or if you need to buy food, you may buy that high calorie, empty carb macaroni and cheese because it will fill you up, but it won't give you any nutrition. Many older adults that are not upper income, regardless of race or ethnicity, suffer from having to make these choices.
Right. And
And it's
right.
really sad. I mean, Meals on Wheels is available, but quite frankly, it's a wonderful program. My grandmother got it, but I took a look at some of those meals, and I don't know if I'd feed them to my dog at times. They're pretty skanky. She would get like a cheese sandwich for dinner, and
Really.
it's better than nothing.
Right.
But sometimes you have to wonder if this is the help the government is giving.
Right.
It's very sad.
Right. And if you're part of a community where there's already a higher risk of developing obesity, hypertension, diabetes, this is, especially
Right.
risky. And food deserts. The communities that are affected by food deserts, especially, are up against the wall when it comes to food choices.
Mhm.
They might be shopping at a Dollar General.
Exactly. No fresh fruits or vegetables, limited protein because, like everything else, especially in today's economy, I mean,
Yep.
our food budget's gone up at least by a third in the past couple of years. And it's a problem, and it's more of a problem on people with fixed incomes or people that can't get to supermarkets because of mobility issues or
Mhm.
transportation issues.
Right.
And it's, well, order your groceries online. Well, that's great unless you don't have a computer and you don't have access to the internet, and the delivery trucks won't go to where you live.
Right.
So,
It's
they're
expensive.
and it's very expensive.
It is.
So, solutions are, and there's a pride thing about going to food banks.
Yeah.
People are reluctant to ask for help, but there are programs and services out there. And I did post a link in the chat to a page full of resources, some of which Travis had on some of his slides, which, we'll talk about some of these programs that can help specifically for AIA and elders.
Yeah, let's talk about that, Liz. What are some of the resources that you highlighted on this list that you find particularly useful for our reporters in the audience? And reporters in the audience, please put your questions in the Q&A. We have a few more minutes.
There are a couple of really good resources. The National Resource Center on Native American Aging is one of them. I mean, it's a potpourri of links to other resources, but it's almost like a one-stop shop where you can go to find links to the Native Elder Service Locator, for example, or the Indian Health Service Care Initiative, which provide caregiving resources. There's also something called the Resource Centers on Minority Aging, and that's abbreviated. You might hear it referred to as a RICMAR.
Mhm.
And there are regional ones that specialize. These are usually academic based, and they specialize in different aspects of aging for minority populations. The one in Colorado, and there is a link on there, specializes in Native American issues. So I would definitely go to them. Stanford University has a website called Ethnomed, which also provides a lot of research papers. Remember, these are academic sites, so you're going to get a lot of the, sort of the
Yeah.
higher level, sites, pros, I should say. but they're good grounding. And what importantly is it gives you an idea of who to talk to, because these researchers are so steeped in this information, and they're more than happy to do interviews with reporters. And if they can't help you, they must know colleagues who can talk specifically if you want to look into Oklahoma or North Dakota, or, you know, these groups are all interconnected.
I have one good comment I want to highlight from our Q&A. Somebody pointing out, Diana is pointing out, dental health issues are usually not mentioned. One must have healthy teeth, gums, and bone to chew and eat healthier foods. It is so true. The issue of oral health, dental health access in some communities is so serious, such a serious problem in so many communities. Are there any solutions that people are working on that either of you know about for oral health access?
One of the things I mentioned earlier is that many people who are eligible do not sign up for Medicaid. And it may not be the greatest solution, but Medicaid does cover oral health. They will cover preventive care, they will cover cleanings, they will cover x-rays, and a limited amount of actual care like fillings or dentures and so on,
Right,
particularly if it's medically necessary. It still boggles my mind in this country that we don't have dental coverage under Medicare.
Yeah, it's pretty disgraceful, actually.
Yeah,
And a question from Nicholas: do you find differences in Indian healthcare between Canada and the USA? FYI, Canadian status Indians work in the USA through the 1795 Jay Treaty. Anyone know the answer to that? Differences in Indian healthcare between Travis?
I don't know how it is in Canada, but if it's anything like IHS, they're probably not as good as IHS has failed. I mean, it's gotten better over the years, but when I was growing up, IHS was something you went and you expected to stay all day, even if it was just for, you know, something routine. I mean, it was an all day affair.
Yeah.
I would hope, you know, with Canada being socialized medicine and all that, it would be better up there. But again, I've seen in the past how some Canadian tribes have been treated. So
yeah,
I
well,
don't know.
Nicholas is saying here in the comments, it's bad in Canada too, apparently. And last question, and I think, Liz, I think this one's right up your alley. Any tips for covering Alzheimer's and dementia in Indigenous communities? I cover both aging and local tribes in San Diego County and have wanted to combine my two beats for coverage on this for a while, but have struggled to find sources to share their caregiving journey.
Okay. Well, there are a couple of resources. One is the Diverse Elders Coalition, which is an excellent resource for this kind of story coverage. There's also the Ethnic Elders Care Network, which is a fantastic resource because it's designed specifically for caregivers. The Alzheimer's Association, I mentioned the Healthy Road Brain Initiative for Indian Country. That's put out by the Alzheimer's Association, and they're very responsive and can find, because they have so many local chapters, they could easily find you somebody local to talk to.
Great. Travis, anything to add?
As far as Alzheimer's, and not really. They were just, when I left Oklahoma in December, the Cherokee Phoenix, they were really starting to pour money into more mental health because of all the, you know, the COVID stuff and you know, people needing mental health issues taken care of over, you know, video chats and stuff like that. So they were starting to pour money, you know, the Cherokee Nation was, into more mental health. So I'm hoping that maybe some of that was going towards Alzheimer's and dementia. So.
Yep. Okay, well, thank you very much to both of you for joining us and for the audience questions. And I'm going to turn it back over to Candace to wrap it up.
Great. Thank you, Catherine. And thank you again to our panelists. We appreciate their time and expertise. I also like to thank our audience and will encourage you to subscribe to the NAJA newsletter. You can visit naja.com and follow us on Facebook and Twitter for announcements and a future roundtable in this series. This concludes today's virtual roundtable. We'll see you next time. Thank you. Goodbye.